So well, firstly, to go back a little bit, I'm very fortunate because one of the diseases I've been interested in for the last 2.5 decades is chronic myeloid leukemia. And little did we know when we started the study on chronic myeloid leukemia that it was going to turn out to be genetically the least complex disease. We used to call it genetically the most simple disease, but now we recognize it is not as simple as we thought. Okay, but the long and the short is it's the first human disease where we found that it has a driver mutation in every single CML cell, okay, and which is the founding driver mutation, which is called BCR-ABL. And then the efforts on both sides of the Atlantic led to the development of a drug called Imatinib, yeah, which targets the BCR-ABL protein and literally switches the leukemogenesis off, you know. And I think no one really expected that drug to be so successful. It works very quickly, and it is able to accord most people with chronic myeloid leukemia a survival which approaches that of the general population. Although from a cancer perspective, you don't actually cure the majority of the patient. You just reduce the chronogenic cells to such a low level that most people don't have signs or symptoms. So because of that, there's been many efforts now that once a patient has a sustained deep molecular response, you were able to discontinue the therapy, whether it's imatinib or one of the second or third generation tyrosine kinase inhibitors. Okay? So the most important thing is that the lessons which were garnered from these patients with this very rare disease were then applied to more common cancers like breast cancer, lung cancer, colorectal cancer. And this really opened up the personalized medicine era about 2 decades ago. Okay? And you've got a steady stream of targeted agents. And then, of course, more recently, in the last decade, we have understood the cancer cell's ecosystem, the physiology, if you like, a little bit better. Okay? So then examining the cancer through the genetic lens and then examining the eco-function has led to an additional number of therapies. And so one of them is, of course, the immunotherapies, particularly the immune checkpoints. So there's a lot of excitement about that, okay? But it doesn't stop there, because what we're learning, and we're still in the very early stages of learning how to apply all this knowledge which we are accruing successfully for targeting the cancer therapies, okay? So, you know, the way we think about cancer, the way we think about the classification, the risk stratification, the therapies, it's all changed. And you know, right across from the drugs to stem cell transplant, and now, as you probably know, you have a number of CAR T therapies, including 2 which have been licensed in the US, and one of them is already licensed in Europe as well. Both allo and auto, initially targeting lymphoid malignancies, but hopefully they will also be useful in some solid tumors and other myeloid malignancies. Yeah?